are two most important things in general for SRS and SBRT. These have to do with do you know where to aim? In other words, target or anatomy localization, which is a common problem for all SRS and SBRT modalities. And second, can you hit what you are aiming at, which is at the treatment delivery process. We are going to concentrate on the first element here today, target anatomy localization, which is part of the simulation process. To this end, usually a number of imaging events take place, first in the diagnostic stage, and later in the CT simulation, image registration involved, and the IGRT is employed to make sure that the target is appropriately targeted. All these imaging elements or imaging events take place, and we use all of those three types of imaging events to define our target, and which is called a volume segmentation. As you know, in radiation oncology in general, not only for SRS but in general, segmented computer tomography images or some other type of modality imaging is used. Historically, a frame is used to immobilize the patient and also provide appropriate localization feature. So the frame serves three purposes. Although I will not concentrate on frame versus frameless here, I'm just going to cover just the basic aspects of the frame and its purpose. A lot of clinics still use frame today, but a lot of other clinics use frameless systems. Frameless is kind of in quotation because people still use some sort of immobilization device. But the frame serves three purposes. It helps immobilize the patient. Essentially, you attach screws into the patient's cranial anatomy to immobilize, attach it to external hardware, and which can accommodate localization system in the form of visible markers in the image as it is seen in the bottom of the screen here. This allows to utilize an external coordinate system to precisely identify any point within the imaging system. It is called a stereotactic localization. As I said, I'm not going to focus on this virtues of frame versus frameless. This may be covered later in one of the other lectures. But in general, if a so-called frameless system you used, this is the system from BrainLab. It could be something else also, but it has several components, and it allows patients to be immobilized within a mask system. So this allows to set the patient in the mask system and reproduce the position on the treatment table. It even allows use of some sort of stereotactic, or in other words, an external fiducial system attached. This way you can easily localize the patient anatomy in CT, and it can be utilized to set up the patient in the treatment delivery end. It typically requires scanning the patient in a so-called SRS protocol, which I will go through this later. The patient is obviously in the supine position. A number of images are acquired. Depending on the imaging and the system limitations, there might be a maximum number of images that has to be acquired. This is the second generation of the Brainlab system. It has a kind of a more sleek table attachment and then a so-called three-point mask system, which allows the patient positioning on the treatment table by use of stereotactic KV images, as you see on this side. There are other mask systems which pretty much do the same thing. These are just two examples. I didn't actually put which vendors they are, but you can see maybe in one of them, this might be a European system. This is probably one of the systems from the US. In either case, there is a headrest, there is a mask system. Nowadays, with more and more use of surface-guided imaging, people started using more and more open, so-called open type of face masks, which allow patient anatomy to be visible to an optical imaging system to monitor the patient position or even help position the patient. A couple of things you need to be paying attention during the simulation, treatment planning phase, and also which will make you make some decisions. Anytime you have any kind of immobilization system with these ancillary supporting systems, you have to pay attention. For instance, this one, you have to pay attention to the density of this material, and you have to include the entire thing in your scan geometry so that you can model these appropriately in your treatment planning process. But selecting an appropriate field of view will affect your axial resolution, pixel resolution. So you have to keep this in mind also. Speaking of which, there are a number of factors that affect the quality of the image. These are essentially noise, resolution, low contrast resolution, or high contrast resolution. I will not spend too much time. This slide is from Dr. Magnet Gray's and AAPM annual presentation from 2009, I believe. He talked about trade-offs in CT image quality and radiation dose. Radiation dose is also another consideration, especially for pediatric patients. So you have to be cognizant of this. And obviously, if you want to get a good image with low noise, you have to use NMA or NMAS value high enough to reduce the dose, but at the same time, it will increase the dose to the patient. So they have to be cognizant of this. I will specifically cover the issue of the resolution, but you may review this particular presentation from Dr. Magnet Gray, which talks about the low contrast resolution, high contrast resolution. For instance, low contrast resolution is the resolution, the ability to resolve two objects which are close to each other in the Huntsville units by probably not more than 5 or 6 Huntsville units. So, I mean, if you have an object which is very similar to in a background image, and then, to be able to resolve this in a low contrast resolution has to be high. And you can probably understand what high contrast resolution means.
We have a question from Fishawi. He's asking about hard SRS mask. He says, do we need a headrest in the treatment or only for simulation?
Okay, let me go back to this if I can. For some reason, I'm not actually, it doesn't allow me. Okay, I jumped too much. Maybe I can go back. Typically, what is done is in the radiation oncology departments, this hard wedge or sponge sometimes replaced by a shell of plastic, which has a minimal radiation transmission, actually, property. In many centers, you use this particular system, uses that particular, headrest, but there are options to use because this goes with a similar geometry, but with an empty plastic shell, which has a minimal density to be able to treat through. In either case, you have to pay attention, maybe you have to test the transmission values of those systems in your radiosurgery arsenal hardware. That's one of the issues, actually. I wanted to raise awareness because there was a couple of years ago, there was an issue in the community. One center tried to include the heterogeneity correction within the whole system, and they included in the body. But that TPS system did not accurately incorporate the heterogeneity correction for the ancillary device. And then later they addressed that issue and corrected it, I believe. But in any case, you need to do maybe some testing, and hopefully before you start doing your radiosurgery service, you have to do maybe an end-to-end test, which will be subject of one of the later lectures.
Another question before we continue is, what is the preferred resolution type, high or low? I don't understand to which it's Mer-Zer that's asking this question.
Okay, I'm going to cover this right now, actually, and we will spend quite a bit of time on this particular issue.
Okay, thank you. Thank you so much.
Resolution refers to two things, right? One is this longitudinal direction, which has to do with the CT slice thickness. And typical slice thicknesses that are used in radiation oncology setting are most likely like, 3 millimeters, sometimes 2 millimeters, but occasionally 1 millimeter. Obviously, this will reduce the, resolution in the Z direction, longitudinal direction. For SRS, most protocols require a 1 millimeter resolution. There is, in the previous slide, I mentioned this actually, those factors are kind of interrelated because when you actually reduce the slice thickness, then you actually also increase the noise, right? So there is a fine line. You cannot probably go too much below 1 millimeter. And also it is related to your particular CT scanner. Your scanner may or may not be able to get it may not reconstruct CT sub-millimeter, and you have to test this, okay? And as it mentioned in the previous slide, there are multiple factors. Even the reconstruction algorithm affects the resolution, okay? In the axial plane, which is defined by the field of view, the information is represented by 512 by 512 pixels. So pixel resolution is going to depend on the reconstruction circle diameter. Typical small diameter that is used for frame-based radiosurgery, because you have minimal hardware, right? You can accommodate a stereotactic frame, in the field of view of about 25 centimeters, which will give you about 0.5 millimeter resolution, right? But as you start using other types of immobilization devices, such as those masks and ancillary equipment, you have to have them modeled in your system so that perhaps there might be some other attachments. You have to see in your planning to be able to avoid through those sections of the hardware. So necessarily it will require you a larger field of view. And as you increase the field of view, the resolution in the axial plane will go up. But the desired axial resolution is a sub-millimeter, not more than this usually. We typically use in our clinic about 370 millimeters, which corresponds to just above 0.7 millimeter, just because we need to include some of the hardware in the scan so that we can model it in the treatment planning process. Now, how does a slight thickness affect the target delineation? This is a study which is not too long ago, in 2014, by a group of people from Henry Ford Hospital in Michigan, Detroit. They did look at the slice thickness and field of view and the impact on how target delineation is affected. This is a representation of a particular case they did. A single user contoured these structures in axial, the sagittal plane, I believe. But you can see that, sup infractions. And the GTV in this case was contoured in 1 millimeter slice thickness CT slice, reconstructed 1 millimeter slices, 2 millimeter in red, and 3 millimeter slices. You can see that even though in the axial plane there are some changes in the sup infraction, if you see here that 2 or 3 millimeters, especially 3 millimeter, misses some of the information in the longitudinal direction. So it definitely affects what you capture in your imaging in terms of the target value by just changing the resolution in the Z direction. They have a similar image. They have also seen some changes in the axial plane. If they increase the axial dimensions large enough, then they see that the contours they delineate are affected. Any questions on that?
There was one question with regards to the field of view. The question was if the field of view is representing the axial tumor diameter, but it was answered within the chat. So there was a misunderstanding of what was meant by the field of view when you talked about the field of view earlier.
Yeah, the field of view refers to when you set your scan parameters on the CT scanner, it asks you field of view. In other words, it will ask you, okay, what diameter of a CT reconstruction circle it should actually be selected, okay?
Thank you.
Sometimes you can extend this for large patients in non-radiosurgery setting, actually. It can be, reconstruction circle can be expanded beyond even, acquired data, by extrapolation, but that's not the subject today.
Yeah, we have another question from, she says, I understand the resolution can be affected by various variables, but for high resolution, do you recommend any specific filter, Hamming, Ramlack, or it is something that varies with localization?
Can you repeat the question? The filter?
She said that I understand that resolution can be affected by various variables, but for high resolution, do you recommend any specific filter, Hamming, Ramlack, or it is something that varies with localization? I don't quite understand.
Well, this has to do with your actually CT scanner, particular CT scanner. So the vendors, actually, there are several studies in the literature they publish, and there is one study comparing different construction methods with different systems from different vendors, like, Siemens scanner, Philips scanner, GE scanner. As I said in the one of the previous slides, because even the type of the filter and also reconstruction algorithm is used, the end result may be different. Okay, so typically the CT vendors will provide you a list of protocols with certain parameters. What you need to do, you need to test if I increase the MAS, for instance, a little bit, or am I gonna get better image, or can I do? You can actually do some testing within your clinic with your own CT scanner. I cannot tell you use this filter or this setting, this particular setting, because it will be dependent on the particular vendor's product.
Yes. Okay. We have another question. It says, when starting a new SBRT program, do we need to set new parameters for the CT simulation? So I guess new protocols.
Yes, absolutely. The purpose of this lecture today is to raise awareness of several key issues. Okay. And after reviewing these concepts and some of the data from the literature, you will have a better idea of what things to consider. Okay. Maybe we can come back to this one at the end of the lecture.
Okay, thank you. Yeah.
Okay, because there are several things that we need to pay attention.
Okay, thank you so much.
CT, slice thickness, field of view are just one of the issues. As I said, there are other things that are important, but I'm not going to go into detail in each of those because that's going to be an imaging, lecture by itself.
Yes, I understand. Thank you.
Okay, but very good actually question. And actually, this is an opportunity for all of us to understand some of the issues that are actually relevant in our clinical settings, but sometimes we don't have time to look at those. We just follow, some protocol or some procedure that is set even before us. And then, but perhaps in non-patient setting with phantoms, you can test those different settings and then find the ideal situation for your patient. Why is it imaging, important? So I just want to raise another issue here. This is a study done among, 7 cyberknife centers, published by Yamazaki in Radiation Oncology in 2011, so a 10-year-old study. So what they did, they asked those 11 clinicians, including radiation oncologists, neurosurgeons, etc., to segment or contour certain type of diseases like pituitary adenoma, meningioma, etc. Okay, and these are the variations of the volumes, PTV volumes, entered by different individuals on the CT image alone. So the reason I'm talking about, how important it is to get the best CT is to allow your clinician to have the best information. You can see that, there is almost, close to 2.5-fold variation in the volume for the pituitary adenoma and meningioma even actually, there's a large variation if those clinicians use only the CT information. Another study, almost close to 10 years, which was recently published, they did also individual target volume contours on CT for various cases. You can see the variation for brainstem, for instance. This one is perhaps an acoustic neuroma, etc. But you can see the variations in the volumes that are entered by different clinicians. So this issue still remains. In the earlier study, what they did, they incorporated an MR imaging. When they did that, you can see that the variation among those clinicians is reduced.
Sorry for interrupting. We have 2 questions regarding this. We have one that says, exactly, is it the mission of the CT vendors or is it the responsibility of the CT vendors to provide specific protocols for acquisition for each type of technique? And one is related to MR. Hassan is asking, we are using MRI with 1 millimeter slice for SRS and SRT by using gamma planar, gamma knife. We are not using CT. Should we go for CT alone? These are the 2 questions that we have right now from the...
Okay. Well, there is one particular issue regarding the vendor's responsibility. Usually they provide protocols for certain anatomy settings. The reason is because they already tested these protocols in their settings for various situations, and then they come up with these parameters. These are initial suggestions. You can actually fine-tune those, but also allows you to start from somewhere, okay? Let me give you an example. For instance, you might be doing, your CT scanner may have a 4D capability, but if you randomly select certain parameters like MAS or some other fine slice, etc., you may not be even actually able to complete the scan without heating the tube too much, right?
Yes.
So those are not only to get good images, but also operate within certain limits of the machinery that you have, okay? So those are the starting points. And then you can, what we did, we have those settings in our clinic. I'll give you an example. And then we also, some of our physicians, especially in abdominal scans, they were not happy. So what we did, we talked with our imaging physicists in our center. Look at their protocols they use in the diagnostic setting and compare them, and we changed some of those settings. We have a standard SRS protocol with a specific MAS, always 1 millimeter, not 2 millimeter. In the past, we did 2 millimeter. And then,
can you please mute your mics if you can? Thank you.
So this kind of conversation, allow us to fine-tune our own scan parameters. We have to, in some settings, sometimes we push the system too much. Like, we want to get the best image, but then sometimes it forces the system to stop because of the tube heating and stuff. So you have to be careful of all of those factors. The bottom line is you need to find high resolution image. If you use the smallest field of view possible to scan the anatomy as well as the immobilization device that is in the field, right? That's my first advice. Second, use at least 1 millimeter CT slice thickness. And if your system doesn't do that, then you can try 1.5 millimeters, maybe, or if that doesn't work, 2 millimeter, but then you have to recognize that there's going to be some information loss, okay?
Thank you. Thank you.
And we're going to come back to the other issue about the gamma knife, okay? I have a slide on that also later, which covers that particular subject. Because then, we have the next issue, MR distortions, which is a large issue in SRS. Coming back to this slide, so the introduction of MR into volume segmentation helped reduce the variation among those clinicians when they identify those structures, the volumes, PTV volumes, significantly. So we can obviously use MR. MR is absolutely a wonderful imaging modality. So in this setting, typically CT and MR information are combined in a process called image registration. Sometimes people also use image fusion. Image fusion refers to blending those images to get the visual information, but the actual combining the information is called the image registration. In other words, mapping one part of the anatomy to another part in the other imaging modality is the process of image registration. CT provides high spatial fidelity. There are typically no geometric problems with the CT scanning, okay? In general, there might be some artifacts, and then those can be avoided with careful, planning. But MR has some issues in terms of, distortion of the structures or the MR inhomogeneity, etc. I'm going to cover this. But MR at the same time provides enhanced soft tissue contrast. But the spatial fidelity is compromised. So you have to be very, very careful about MR when you use it alone in the planning process. So first of all, again, ensure that you are using a suitable resolution for MR. Evaluate distortion. I have some actually slides from several studies, I think, which some of them came very recently. It is important that you review those work so that, you become familiar with the issues. And then, you use the MR imaging with caution. evaluate distortion, evaluate motion artifacts. Obviously, a lot of MR imaging is done in the radiology department in their MR scanners, and then most of the stereotactic immobilization systems are not necessarily MR compatible, so people don't use them in the MR setting, okay, and which introduces the problem for motion artifacts. I have seen some examples, patient move their head, you can see those very blurry images, and so those are the problems that you have to recognize. If the image quality is not good, you may even have to have a repeat scan and assess registration to planning CT. So the process is whole scan, typically scan align, anatomy within 1 millimeter everywhere. So I mean, this is the first level of checking, right? Useful for structure definition everywhere, appropriate for stereotactic localization. And then after you register, make sure that anatomy local to the area of interest is undistorted and aligned within a millimeter, which is useful for structure definition within the local region. Appropriate for localization provided targets is in locally aligned region. So those two are required for SRS application. You have to have fine resolution scan and a good alignment with the entire anatomy as well as the local anatomy that you are concerned with. Some deformation may take place between the MR and CT. This is a slide from Richard Popple's presentation from Astro just last month. So I actually took it from his slides, but then he shows that, between the MR and the CT, there is actually some distortion and also some shift, right? So you have to be very careful about this. This can happen. Now, I don't know if you recognize this, but I use the term here bootleg. How many of you know bootleg, what it means? So essentially you go to a movie theater and then you record the presentation or the movie, and then you take it out for other purposes, and it is called bootleg. Okay, so that's what I did shamelessly, but I think it is very useful here.
Yeah,
because he is showing here. I'm gonna just run this movie, and you can see his voice behind. So this is actually an image. Images are taken in the same study, but because of the start position or the table position change in between those series, you can see that there are differences in the. So I just don't take those images blindly and assume that they are registered perfectly. You have to check them. If you are going to, for instance, typically we have different sequences of images from MR for SRS intracranial applications, typically a T1 series, or sometimes, depending on the disease, the physician may use some other series like BOLD or something to differentiate, maybe some other structures. And in that case, you have to actually register the CT with those particular MR sequences carefully. I'm gonna just go to next one. So this is another one. This is very interesting because Richard Popple's talk was on functional imaging and how you do it with the modern LINAC-based SRS or actually any systems. And in his presentation, he also indicated, this is also and represents some offset between image series in the same study. In this case, functional one, actually, they are treating the nerve, maybe trigeminal nerve. And you can see in the coronal plane, the nerve in the L shape. In this movie, you can see how it varies, actually.
This little L-shaped hypointensity region is where the nerve is passing the CSF and was our target. In our practice, the image registration happens initially by.
So those kind of problems may arise. So you have to be really careful to check the integrity of those images with respect to each other, and also dutifully, register those MR images with the CT and validate the registration by checking different parts of the anatomy, just like this one, for instance. This kind of actually tools are available in many planning systems. This is called, in one planning system, spyglass. You can move it around and you can check the agreement between, for instance, for the sulci, whether in this case, this is an MR image and then magnified here. But almost the same idea. You can move this window around and then check the underlying image set is agreeing with this overlying image set. This particular slide shows a study looking into resolution issue for MR, how important it is. In our practice, in our center, occasionally we see this problem because, again, is another department. We have standard SRS protocol, but sometimes for some reason it is missed, and then they scan the patient, and then they tell us, okay, well, we scanned the patient, but we can reconstruct the images with finer, slice thickness, and it doesn't work. Actually, they have to actually acquire the data appropriately and then reconstruct them, in a fine resolution images. In this case, metastasis is visible on a 1 millimeter MR, but it's not visible on 2 millimeter or 3 millimeter. So in this case, you will actually miss this if you are using a 2 millimeter or 3 millimeter MR versus 1 millimeter. You have to have an appropriate, the SRS protocol for all of your imaging modalities. Another problem, the same study, this time on 1 millimeter slices, they identified this as a blood vessel, but on 2 millimeter, it looked more like a met. So if they used 2 or 3 millimeter slices, they will use this one. They will misidentify this structure as a metastasis as opposed to what it is really. It is also useful to collaborate with the neuroradiologist. We do this in our center. When the physician is in doubt, they collaborate with the neuroradiologist. They bring that person in. They can look at independently, and then they can give their opinion on this because they are trained for identifying structures and recognizing these kind of issues.
We have a question from Isam from Morocco. His question is, what is the best, registration limited to the region of interest versus registration of all the anatomical region?
So that's a good question, but sometimes there are anatomy changes, swelling happens, especially after post-op situations. If the scan, there is also a requirement for this, usually not more than 48 hours. You have to check both, actually, first globally and then locally. And then you have to optimize it for the area of the most important area that you consider. If it is the target, but if the target is close to, for instance, some very critical structure, then obviously you have to optimize the area of interest to include both the target and also those structures. But it's a good question. You don't have to, for instance, in this registration, you can select an anatomy volume to the area of your most important interest. Okay.
Thank you.
Including the nose of the patient, maybe chin, etc. Those areas can be excluded. So the brain has to be up, the prioritized, especially the area of your treatment and also concern for OARs. So another important issue with the MR has inherent problem with distortions. And these distortions rises from several factors. And some of them can be addressed by doing some corrections, but some of them cannot be corrected entirely. Because MR distortion happens primarily due to 4 distinct reasons, which is inhomogeneity of the static magnetic field, nonlinearity of the gradient magnetic field, magnetic susceptibility of the tissue, chemical shift artifacts of the tissue. Of these, you cannot entirely correct for the magnetic susceptibility of the tissue because the object that is scanned has an inherent magnetic susceptibility that will introduce some distortion. In the more radiology departments, what they do, they use a phantom with a geometric pattern of markers or fiducials to they scan this in their scanner, and then they will apply a correction. So most of the time, the images that come to your department are already corrected to a larger degree. But that doesn't mean that there are some remaining distortions still exist in the MR. Other type of correction involves with the software, and one of the systems that utilize this type of approach is the Brainlab SRS system in their elements distortion correction package. This slide summarizes the method here. Essentially, they apply a deformable registration excuse of the brain, and then they do some deformation based on the distortions of the R in the field. This work is validated actually by several studies and shown the utility. This way, you can actually get an accuracy beyond traditional rigid registration. There are some examples of this. I'm going to show you later. But what happens actually, you don't actually correct for MR distortions in the image sets, okay? Here's a study, which is only 5 years ago. Distortion inherent in magnetic resonance imaging can lead to geometric miss in radiosurgery planning. This is a specific problem that was studied by this group in this journal, Practical Radiation Oncology article. Essentially, they look at 28 patients and how magnetic resonance distortions can lead to displacements resulting in geometric miss. In this case, there are 3 outlines which show corrected gross tumor volume in the cyan. Yellow color shows the outline of the distorted target with displaced centers of mass up to 3.4 millimeters, 3.9, 3.9 millimeters on different views, different patients. Volumes of red not covered by 90% of the prescription dose. Next slide shows you this nicely. So the displacements, mean displacement in excess of 1 millimeter and up to close to 4 millimeter can result of almost entirely miss of these structures in the radiosurgery planning. So the MR distortions are this important in the process. Another obvious issue is nowadays, a lot of people use, more and more people at least are using, treating multiple meds with a single isocenter, right? This kind of displacement due to the magnetic field distortion or MR imaging distortion can again result in misses or under treatments or over treatments, in some case actually over treatments of the normal tissue. In this case, you can see that location, for instance, right lesion, in this case, depending on how you set your center of actually the isocenter, some of them may not be as affected, but some of them may be affected more. This study looks...
I have another question from Isam. He says, is it necessary or recommended to do the MRI in the position of treatment and with the immobilization devices?
If your immobilization device is MR compatible, it is absolutely preferential to do MR scanning with the MR SRS immobilization, or at least maybe use compatible headrest to have the head position, rotations, to keep them, to a minimum, because then there is going to be less registration errors. The closer the position is, the better is actually, because essentially when you register, you are mapping anatomy from one modality to another one, and you are reconstructing, at the planning CT in a geometry, okay? If there are problems, distortions, they are going to be translated into mapped anatomy, and it's going to increase the significance.
Okay, thank you. There's another question from Egypt. She asks, do we have special QA protocols for MRI distortion before contouring? Do we need to do anything before contouring?
Unfortunately, a lot of actually the planning systems don't have tools. This particular planning system is one of the ones that I'm familiar with. They actually allow you to look at the MR distortion and check it. And some of the images are fine. Sometimes others are not fine. But the best thing is, for instance, when you register your MR to CT, because the CT essentially is spatially more accurate, right? You can actually check the position of those, for instance, the eyeballs, right? And how much displacement there are. And that will give you some idea of the distortions that exist in the MR. In other words, look at some fixed anatomy on the CT and then compare it with the MR, or vice versa.
Okay, thank you.
So this study looks at the potential impact on the target coverage, especially those under 2 centimeter or 20 millimeter targets, you can see that in this case, because of the displacements, the target coverage was significantly compromised with differences greater than 5% compared to, the Paddock's conformity index values change more than 5% for those targets less than 20 millimeter in diameter. This is for a target size showing 10 millimeter with different offsets. No offset is the blue one. You can see as the offset increases, you can start seeing that, the 90%, 95% coverage line goes down significantly. And obviously, a 3 millimeter offset is very, extremely, concerning. So the question was asked on the MR distortion and the impact on the gamma knife. So especially is used for gamma knife. Again, it has to be checked, for accuracy. If you are relying on MR entirely, you might have problems. Multiple studies actually looked at this, failure rate of contemporary low-dose radiosurgical technique for vestibular schwannoma in this study. So they look at essentially the issue coming from the MR imaging versus computed tomography. 3 problems. MR distortion is greatest at tissue interfaces. Konzialka, this is one of the very prominent neurosurgeons, showed that MR versus CT for localization can vary the location of the target by as large as 2 millimeter. And also another study showed variations up to 2 millimeter can exist to, MR scanning. So these distortions can be either removed via elastic correction to a stereotactic CT, as in the previous example. So the software allows you to address this issue by mapping, the anatomy correctly to the CT with elastic registration. Rigid registration doesn't do it. Okay. Now the question is, should I use cone beam CT? Using cone beam CT is not an easy thing. Okay. It has some other issues. It also has some artifacts, and you have to appropriately calibrate your cone beam CT to do those calculations. It is good for checking the precision of your targeting, but if you want to do those calculations, then you have to go one more step, and then you need to validate this with appropriate calibration. And it's not very straightforward. There are actually some papers on that in the literature. So this actually shows an example from the software. There are 2 cases, a case distorted versus undistorted. So when it is mapped, it shows this kind of change in the anatomy when it is mapped with elastic registration. Okay. So we covered CT, we covered MR. So what other imaging modalities are used for SRS simulation? Typically for AVMs, the deformations of the blood vessels, treatment requires a correct identification of the location of the nidus. So this can be done most accurately and correctly with digital subtraction images, which are registered to CT and MR through a stereotactic localization. A lot of times the registration requires some sort of hardware, but then it usually requires some attachment to the system with the fiducials. But then nowadays there are also done this automatically in terms of the automatic CT angiography or MR imaging. Okay, so this is another tool that can be used for target localization for AVMs. In summary, I'm going to point out to a recent publication. It's an expert review group from the DGMP Working Group for Physics and Technology in Stereotactic Radiotherapy, which was published in this German journal last year. They give a number of recommendations for each side, essentially for radiosurgery and SBRT. For intracranial, their recommendations are summarized in this slide. Essentially, maximum slice thickness should be in not more than 1.5, with minimum field strength 1.5. So, if you have an old scanner less than 1.5, that is also a concern, because then you will not be able to resolve some of those small spatial lesions. Maximum possible in-plane resolution. This has to do with the field of view, remember? It has to be less than 1 millimeter. Another thing that has to be paid attention, planning images should be less than 1 week of treatment delivery. Okay, when you do the planning CT scan of the patient, you should plan and deliver the treatment within a week. If it exceeds a week, then you need to resimulate the patient. For post-op cavities, they should be within 48 hours because then there is going to be significant swelling and displacement of the cavity with respect to your CT. If you take the CT after actually MR or MR later than 48 hours, you have to be cognizant of this. And there are different imaging sequences that are modalities that are recommended. Any questions up to this point? So I have another 10 slides or so, and it's going to concentrate on mainly on the spine. For the intracranial, this is what we have. Essentially, several things which I'm going to actually come back and, maybe reemphasize those points. But up to this point, is there any other questions?
I can't see any other questions from the group in the chat.
Okay. So the spine is obviously, we sometimes call SRS, SBRT, and separate them as stereotactic body radiation therapy and stereotactic radiosurgery. Probably with those schemes that are used in the treatment of the spine, this is probably closest to spine SRS, and it requires very precision of a targeting of a target volume very close to a spinal cord. And it usually requires an external immobilization systems primarily designed to control the patient motion during the treatment. Otherwise, you have to have a robust imaging system that frequently images and provides you feedback in the position of the patient during the treatment, which is going to be covered with another lecture later. Okay, I'm just going to actually mention that some sort of immobilization and hopefully a good immobilization system is essential when you do the spinal SBRT. And all of those systems look very similar. It almost makes you wonder, oh my God, where did they get this idea? And I said imitation is the highest form of flattery. So I was at Memorial Sloan Kettering Cancer Center in New York, and my collaborator with Vendalas, we designed a body frame back in the day and used these, not only this, anterior, but also lateral compression plates to position the patient and also fix the patient in the body frame. In this case, at the time, the online imaging systems, the OBI, Combeam CT were not available. They just came about the same time, maybe later in 2000s, okay? But we had a CT scanner in one of the treatment room, which could be aligned with this treatment room. So we scanned the patient from the CT scanner, moved the patient from the CT scanner to the treatment table, and then position the patient. And we call this one the stereotactic body frame. In short, it is called the SBF. So some people complain that, it was a pine box because it was made out of, pine wood. So it didn't, some people made it look like, sounded like, it looks something, that people are put in after they die. So we decided to paint it with blue color. We called it blue frame also. But this was published in 2003. And then a lot of people, vendors, I talked with vendors. I wanted to actually market the system, but then they got the idea and then they started imitating, our immobilization system, which is fine. It's all good for patient care. But essentially, the idea is still the same. You have some sort of foam or maybe alpha cradle that is actually inside the frame and some external, pressure plates that fixes the skeletal anatomy. So I'm gonna just actually go through, what we do here at the UCMC. So what we do, we actually do the mold reconstruction. We use the very first one that we use, actually, the commercial system from the CDR. It has the full body, vacuum bag. We place the patient, we make the mold, and then we position those external anterior bar to the patient's abdominal area or maybe sometimes to the pelvis. And then, we scan the patient with the spine SBRT protocol, which requires 1 millimeter slices continuously. For T-spine, the arms, especially for the thoracic spine, if you want to avoid the arms in the treatment plan, or maybe, you cannot visualize the spine very well in the lateral images, you need to have the arms positioned above the patient head. Sometimes patients cannot tolerate it, In that case, you can have the patient relax and then put their hands in a reproducible position, and then maybe you can capture the hand position inside the body mold. For L spine, so you can actually, top edge should go above the abdominal area to the chest, and you can use the headrest, arms on the chest could be okay, and verify if the elbows are out of the field and scarred for high spine cases. We typically place 3-point reference marks to mark the patient and additional straightening marks on the images, which allows us to position the patient, straighten up the patient on the treatment table. Some of the initially, and we didn't do this very recently, but occasionally we do CT myelogram, especially helpful if there is an epidural intrusion. If there is no myelogram, you can actually use the spinal canal as the guide, and then, or the thecal sac contour of the spinal cord with the 1 or 2 millimeter margin beyond the spinal cord is the PRV. So the CT myelogram helps. In this case, a sagittal image, you can see that, the spinal cord is segmented here, but it is very nicely delineated here. You can see the true spine. Another image, this is a T-spine image, actually. One of the problem is actually the curvature of the spine. So for that reason, it is important that you have a good body mold, which positions the patient in a comfortable position, but also reproduces the patient in the treatment position. And the markers allow you to check the alignment correctly. And then you need to have enough anatomy scanned to do the alignment imaging. In this case, we have the spinal cord nicely, enhanced in the myelogram, which help us to delineate the target with the exclusion of the true spinal cord. And sometimes, this area is this is the area where most of the, failures happen. So you have to really delineate this and control the dose fall off within this region in the planning process, which will be covered in another presentation. This is the plan that we did, showing that actually how the plan was realized based on this information that we had in the CT simulation. Another problem is the flex of the spine. Sometimes it doesn't match. And then, you might have a diagnostic scan. Again, software correction with the elastic registration of the spine may help. So you need to use these tools after validation carefully, that you can correctly identify those vertebral vertebra and contour those structures. The importance of the enough anatomy. Obviously, we are only treating this area or in this area in the KV images, but then you need to have enough bone anatomy to position the patient. Initial positioning is extremely important for spine. Sometimes the therapists, they rely too much on the 6th of couch, and sometimes there are rotations. You have to have those rotations taken out in the treatment setup process to be able to do a successful, image guidance. In summary, from the expert review group, this is what you need to do: a high resolution CT, preferably 1 millimeter scans, MR, and PET also, if you have some bony targets. T2 weighted MR can be helpful, and the CT slice is usually 1 to 2 millimeters, depending on volume and location, and T myelogram for spinal cord delineation or T2 weighted MR. Any questions up to this point? In conclusion, scan resolution affects target segmentation accuracy. At the minimum, follow published guidelines such as expert review group from the DGMP working group, as indicated in this presentation. MR distortions can be very significant if not corrected, and it may affect adversely, what you are trying to do. It may cause misses, misidentifications, etc. Most SRS and SBRT cases, both intracranial and spine, require multimodality imaging. So you have to rely on those images, but then you have to check the fidelity of the image registration by careful analysis of the registered images. Addressing the patient positioning issues during the simulation pays off dividends later, especially in the treatment delivery. A problem which is not fixed at the simulation, so most of the time cannot be fixed in the treatment delivery end. So instead of sending patient back and then redoing the whole process, review the images and information right after simulation, and then if needed, address those issues in the simulation. And in the upcoming lectures, you will see specific case studies for both spine and brain.